I'm not a paediatric surgeon. I deal exclusively with adults. I spend most of my time removing cancers of the esophagus, but I have a particular interest in complex benign problems, and particularly those in patients who were born with TOFs. So I see more and more patients with some very difficult esophageal problems. The esophageal surgery, certainly when I was a medical student at Guy's in the 1980s, esophageal surgery was thought to be very difficult, very high risk, fraught with problems. And this slide is not someone who had a TOF, I can assure you. But esophageal surgery, certainly in the last decade or two, has really become much lower risk, much more straightforward. It's still very major surgery, both in children and in adults, but I think the outcomes have improved vastly in the last decade. And a much greater emphasis now is placed on functional outcomes from esophageal surgery. And that's really what I'm going to talk a bit about today. This actually is I'll go back. This was a patient of mine who I saw very recently. And I think this summarizes really what the problems are. And she said to me, the problem is I see all these specialists who look at the problem in isolation and not in the context of someone who has had a previous TOF. And she had recurrent pneumonia. I'm not going to talk about respiratory disease, but you've heard a lot about it already. But of course, it's intimately related to the esophageal problems. She had reflux, dysphagia, bowel disturbances, and was being referred from pillar to post, seeing individual specialists who knew a bit about that, but never pulled it all together. So this is the slide patient I was talking about. This is the first ever esophagectomy done in 1913. As I said, there's a much greater emphasis on functional outcomes now. This was a patient who had a cast-end esophagus. They took the esophagus out. They didn't know how to reconstruct in those days, so they used a bicycle inner tube. That's the bicycle inner tube. It's stitched into the esophagus in the neck, and it's stitched into the stomach there. And this patient survived for 10 years on a liquid diet before dying of a heart attack. Quality of life perhaps wasn't very good, and as I said earlier, there's been a much greater emphasis on functional outcomes from esophageal surgery now, but a pretty heroic feat more than 100 years ago. As we've heard already, it's the commonest congenital abnormality of the esophagus. These patients do get a lot of problems in childhood, and you've heard about that, and I'm not going to talk about children at all. There's very little in the literature about problems that the adults get, but the esophagus is very, very rarely normal in the patients who are adults when they've had a TOF. Many get strictures, dysmotility, the esophagus doesn't work very well, reflux, all very common in adults, and these all have a profound impact on quality of life. And I get increasingly asked about Barrett's and cancer of the esophagus. Is there an increased risk? And it causes a lot of concern. So why do TOF patients get all these problems? Well, the anatomy is disrupted. You have a loss of normal anatomy, and therefore it's not surprising that it causes problems when they get to adults. The length of the gap that they're born with is very important, and that has an impact on the degree of problems patients get. The type of anastomosis, the way the reconstruction is carried out, whether a conduit is used, whether there's colon being taken up there, whether small bowel, whether the stomach's being taken up much higher. The intrinsic nerve supply to the esophagus below the gap is always impaired. The vagal nerves, which are the two Maynard nerves, are often intact, but the intrinsic nerve supply is disrupted. So the lower part of the esophagus beyond the gap is almost invariably has poor motility and won't function very well. The initial reconstructive surgery may have led to shortening of the esophagus, maybe inevitably. They may have a hiatus hernia, and there may be a lot of scar tissue from that surgery. All of those things have an impact. And patients who've had a TOF, when they get to adulthood, have varying degrees. Some of them don't have any problems at all, but many do have varying degrees of swallowing difficulties or dysphagia, reflux, causing heartburn and regurgitation, and obviously respiratory problems we've heard about already. Now, I'm not going to talk a lot about investigations, but many of you will be familiar with the battery of tests that can be used to investigate the esophagus. Endoscopy is the commonest and has a very, very important role. And I almost invariably say to adult patients who've had a TOF, I need to do an endoscopy. I can't really decide how to manage this without having a look at it myself. So that's very important. Barium studies are really important as well. We've heard about assessment of reflux, 24-hour pH studies, and more recently impedance studies to look for non-acid reflux, manometry, which assesses the muscular function of the esophagus. CT scan can be useful as well, and sometimes nuclear medicine gastric emptying studies to look at the way the stomach empties, because people forget sometimes that the stomach emptying can be impaired in these patients as well. Now, I'm going to go through some of these symptoms in turn. Swallowing difficulty is very common. About 60% of adults who've had TOFs have some degree of swallowing difficulties. Most people just pass it off and don't even seek help about it, but most people do get some degree of difficulty. 80% have about a proportion of those have very mild symptoms, but about 50% or so do need investigation and further intervention. Sorry, this is... and a proportion will get food stuck regularly, have to modify their diet, will regurgitate their food, and it does have a profound impact on quality of life. Strictures, a physical narrowing of the esophagus. The most common cause are either due to the anastomosis, the scar tissue around the join that was done at the time of repair. Occasionally reflux can cause strictures if it's very bad, and the acid inflammation causes narrowing, and they can need dilatations. Occasionally, patients can get extrinsic compression of the esophagus or what's been used to reconstruct it. So if, for example, colon or small bowel or stomach's been taken up, they can be constricted where they go from the neck into the chest, or where they go through the diaphragm from the chest into the abdomen. And they can be challenging problems to deal with. Varying degrees of dysmotility. I talked about that when the esophagus doesn't work very well, it doesn't contract well. The peristalsis, which is the sequential contraction of the esophagus, pushing food down, that's almost invariably disrupted to varying degrees below the gap. And of course, if a conduit's been used, if the colon's been taken up there, or small intestine, or stomach, it's very rare for those organs to contract normally going into adult life. So they will cause a degree of dysmotility and hold up. This is a fairly typical picture of a stricture. This is narrowed down to about 3 millimeters, and you can imagine it's very difficult getting stuff through that. They're not always as bad as that, and you can see on a barium swallow showing a fixed narrowing there. Patients adapt to life with these unbelievably well in my experience, and tolerate liquid diets, very soft diets, and really don't complain. But they are problems, and they do need treatment sometimes. Most of these strictures, the vast majority, can be dealt with by dilatations. Very occasionally we put stents in, and the stent technology I'll talk a bit about has evolved enormously in the last few years. And very rarely we do surgery, but I would have to say I can count on one hand the number of patients whose benign strictures I've had to remove surgically. Pneumatic dilatation, this is one I did recently. It wasn't on a TOF patient, as it turns out, it was on another patient, but nevertheless the principle's the same. You can see the narrow stricture here down to about 3 millimeters. We pass a catheter down through the endoscope. The diameter of that is about 3 millimeters. The balloon is collapsed. There have historically been many ways of doing dilatations, but I think now almost exclusively they're balloon dilatations. We pass a collapsed balloon through the stricture. The balloon is blown up, and we have different sized balloons from 6 millimeters up to 20 millimeters we conventionally use. We start slowly and small and sequentially build up, sometimes over many months. And this is a stricture endoscopically after the dilatation. Now, if it's a mild stricture, we may get away with 1 or 2 dilatations. If they're tight and we do it slowly and build it up, you can do many, many dozens of them. My record, not in a TOF patient, but in another patient, was about 130 dilatations. And that was over about 5 years, and I haven't done it now for 8 years. I still see him, but it worked eventually. So that's an exception, I hasten to add. In TOF patients, I do see patients who do have regular dilatations, perhaps every 6 months. Stents, as I said, the traditional stents were pretty awful, frankly. They were rigid plastic stents and were used almost exclusively in people with inoperable cancers. We now have these self-expanding metal stents, and they have transformed the use of these devices to treat strictures. It's evolving all the time. The technology changes all the time. The initial ones were metal with plastic covers. We've now got pure plastic ones. We now have absorbable stents, which you put in and they just gradually dissolve over a couple of months. We have easily removable stents. The first ones you couldn't remove and cause problems, but we now have removable stents. We still only use them for very difficult strictures, but that scenario of a patient requiring 130 dilatations was pre-modern stent technology. Now, if patients are requiring repeated dilatations on a frequent basis, we put in a removable stent, take it out 8 weeks later, and by which time the scarring has modelled around the stent, and it usually prevents the need for further dilatation. So we can treat strictures now much more successfully than in the past. Very rare do we operate on them, but we do occasionally, and then you just take out a small amount of esophagus and replace it with a smaller bit of small intestine or colon, usually. Occasionally we take the stomach up. And again, that can lead to really impressive functional improvement. Now, that's strictures. Reflux and these are all interlinked, of course. People with reflux get strictures as well. This is a hiatus hernia. You'll all be familiar with this. This is the diaphragm here. Can everyone see? Sorry, I'm standing in people's way. That's the diaphragm there. This is the top of the stomach, and the stomach has moved up through the diaphragm. So the top part of the stomach is in the chest. This may be an inevitability of the reconstruction they've had because they've got a short esophagus, or it may be something that's acquired over teenage years into early adulthood. Now, the main prevention of reflux in us is a sphincter here. The lower esophagus has a condensation of muscle called the lower esophageal sphincter, and that is the main mechanism that prevents reflux in all of us, kids and adults. And if that fails, if that is weak, and it often is in people who've had tracheoesophageal fissures because the intrinsic nerve supply is not very good, that is the major cause of reflux. Having a hiatus hernia where the top of the stomach has gone through the diaphragm exacerbates that and is often a major cause of reflux as well. But the major problem is usually the sphincter there. Now, we all get reflux, even with a completely normal sphincter, but our esophagus, because it contracts well, is very good at then clearing the reflux. If you've got a lower esophagus, which doesn't contract very well and doesn't clear very well, that poor clearance of fluid and food will cause reflux as well. So that exacerbates the problem. So it's multifactorial. There's several reasons why people get reflux, but as you can probably understand why it's such a common problem in adults who had TOFs repaired as kids. Reflux for many years was just considered to be a lifestyle problem, and not a serious problem, just a lifestyle problem. You took your antacids, you perhaps didn't eat quite so many curries or things like that, but it wasn't a big problem. And indeed, the vast majority of people with reflux don't go near a doctor. This pie chart shows these are all adults with reflux. These are not TOF patients. This is a cross-section of the population of the United Kingdom. The vast majority do not go anywhere near a doctor. They might buy their Gaviscon or their Rennies over the counter. They may modify their diet or their drinking, and they cope pretty well. A small proportion go to see their GPs. A very, very small proportion ever come and see someone like me. And of that proportion, only about a third or a quarter of those ever need to have any surgery. So surgery for reflux, although we do quite a lot of it in specialist centres, it's actually a very rare event for someone with a reflux because the vast majority can avoid it, thankfully. But it has a huge impact on quality of life, and those of you who get it will, I'm sure, agree with this. And it's been estimated in many quality of life studies that the effect on quality of life is similar to that of symptoms of other diseases, such as ischemic heart disease. So it's a big problem, and it's very commonplace. It causes lifestyle problems, it causes strictures, we've heard about that. It causes respiratory problems with recurrent aspiration and the reflux spilling over into the lungs. I get a lot of patients referred to me with reflux from respiratory physicians who have been treated for asthma or for whatever problems for many years, and then it clicks, oh, maybe they're getting reflux causing this. They can get dental problems, they can become anemic and bleeding from the esophagitis, and of course there's this question of cancer, the cancer risk associated with reflux. This is one of the many studies that looked at quality of life, and 22% or 60% of these patients found the symptoms very significant. 22% loss of interest in normal activities, couldn't sleep, it impairs sex life, sport and exercise, and concentration. So in all aspects of life, it has a profound effect. What about in TOF adults? Well, this is one of the many observational studies that's summarising this, and about 80% of adults who've had tracheoesophageal fistula repaired as kids will get reflux in their adult life. Most don't see a doctor, most cope very well, but it's a very, very common problem. And this is a schematic diagram looking at the severity of reflux, and this is one of the ways we categorise it, the Los Angeles classification. I don't know if you can see that, there's some red streaks coming up there, grade A, worsening reflux there, grade B, much more commonly here, and you're beginning to get some ulceration forming here, and in grade D reflux you get narrowing, stricture formation and ulceration, really impacting on the patient's symptoms. Now, a lot of patients I see, and I know from talking to people in the organisation, that the cancer risk is a real concern, and I'm going to talk a little bit about that and Barrett's esophagus. We know that reflux is the major cause of adenocarcinoma in the esophagus. The adenocarcinoma in the esophagus is the commonest cause of cancer of the esophagus. In my practice, and I see a lot of patients with it, it's about 80 to 85% of patients with cancer of the esophagus have adenocarcinoma, and that is caused by reflux. Now, the vast, vast, vast majority of people with reflux don't get cancer, but we now recognise heartburn. If you have bad heartburn, you're at increased risk of getting esophageal adenocarcinoma. And the mechanism of that is almost certainly through this condition called Barrett's esophagus. And you can see this is an endoscopy here. The slightly whiter tissue in the esophagus is squamous epithelium. It's the normal lining of the esophagus. The slightly redder is Barrett's. And you can see it very easily at endoscopy when you biopsy it. And the mucosa has undergone cellular change, has undergone what's called metaplastic change from squamous epithelium into columnar epithelium. And we know that is a pre-malignant condition. If you have Barrett's, you're at increased risk of getting a cancer of the esophagus. It's still probably less than 1% of patients with Barrett's who get cancer, but it is higher than the normal population. So it's important to recognise, and we have a very clear strategy for treating it. Barrett's can evolve, so the initial injury is reflux here, and there's various things that can increase the risk of that going into Barrett's and a cancer, genetic factors, and almost certainly, and there's a lot of research, for example, in the use of aspirin to reduce the transformation of Barrett's into cancer. But the sequence of events is a very clearly described one. Inflammation to metaplasia, to dysplasia, to high-grade dysplasia, to invasive cancer. Most people don't go down that route, but it is a well-recognised description now. Now, there is a cumulative risk of getting Barrett's in adults who've had a tracheoesophageal fissure. It does increase as you get older, but the overall incidence is thought to be about 7%. About 7% of patients who've had esophageal atresia will develop Barrett's in adulthood, and that is undoubtedly related to the reflux that is occurring as a result of their esophageal problems. And there are various things, as you can see here, which will increase the risk of that. If they've had a recurrent fistula, if it's a late stricture, if they've got very, very poor peristalsis, all these things will increase the risk. But about 7% will get Barrett's. Cancer, thankfully, is spectacularly rare. There is a lot of concern. I've seen probably 3,000 or 4,000 patients with esophageal cancer in my consultant career, and I've never seen one in someone who's had a tracheoesophageal fistula. There are isolated case reports of people getting cancer. I believe that the risk is very marginally increased simply because you're more likely to have reflux, but no further than that. There are a few sporadic cases of squamous cell cancer, perhaps related to inflammation at the site of the original repair, but these are sporadic cases, and I really want to emphasise that yes, there is a very slightly increased risk compared to the normal population, but that is related to the reflux that people get. And I think with the modern management of reflux and the modern management of Barrett's, that risk can be really minimised. So how do we manage Barrett's? Well, we treat the reflux as successfully as we possibly can. Proton pump inhibitors, omeprazole, lansoprazole, esomeprazole, all those drugs are very, very important. We'll talk about them. I know there are some concerns about side effects, and I'm very happy to talk a bit about that in the questioning afterwards. But we do anti-reflux surgery. We do fundoplications, and I'll talk a bit about that in a minute. Occasionally, not many, but occasionally patients do require surgery to prevent reflux when the drugs don't work. Surveillance endoscopy, this is core to the management of Barrett's. If a patient who's had a TOF, any patient with Barrett's is recognised as having Barrett's, then they should have surveillance endoscopy. Usually, the programs vary according to the length of Barrett's, but on average, about once every 3 to 5 years, one should have an endoscopy to have a look at it and take biopsies. The reason we take biopsies is to look for any dysplastic change. We know there's metaplastic change. We look to see if there's any progression beyond the stage 1, as it were, of Barrett. And if there is progression towards dysplasia, that tells us that there is an increased risk of a cancer developing, and we can now intervene and treat that Barrett's to prevent it becoming cancerous. And the only way you can do that is by monitoring it, by surveying it and looking at the changes. Now this has been a massive change in the way we treat Barrett's compared to, say, 15 years ago, when we had no way of managing, we had no way of treating Barrett's other than reflux, and the only way we could do anything was if the changes occurred, we could then remove the esophagus, which is a pretty dramatic thing to do. But now, of course, we can treat the Barrett's and eliminate it. And it's essentially a combination of two techniques. There's been a lot of things described over the years, but now I think we do it in two ways. This is called endoscopic mucosal resection. So if you see, for example, a little nodule in the Barrett's and the biopsies show high-grade dysplasia, you know that may have a few cells of cancer in it already, or it may develop into a cancer, but it's completely curable if you remove it. So we can do an endoscopy, and this is a schematic diagram. You can put what's got a little snare around it. There's various techniques for doing it. You can suck it up into the scope and you can remove it. Just this very small little nodule, you're leaving the rest of the esophageal wall intact, and that will then heal and you've removed it. Now, you can't take the whole Barrett's mucosa out like that. Sometimes you've got 6, 8, 10 centimetres of Barrett's covering the whole of the lower esophagus. So the way we treat the rest of the Barrett's, i.e. that part without little nodules, is by radiofrequency ablation. And there's been some research looking at cryo-freezing it, freezing it and destroying it that way, using an argon beam and special lights to burn it. But I think the most popular way now is radiofrequency, and it's very easy done. As an outpatient under light sedation, you put this probe down, it burns the mucosa, it destroys the innermost lining, the mucosa only, and that's what it looks like. It all sloughs off. It can scar up, but if you do it carefully and sequentially, it doesn't scar up. And then if you leave them on a high dosage of omeprazole or something like that, the mucosa then regrows as squamous mucosa. So you've eliminated the Barrett's. and you can get rid of Barrett's this way. You still need to keep an eye on them to make sure it doesn't come back, but we can now treat the Barrett's and minimise the risk of it transforming into a cancer. And I think that's been a groundbreaking change in the last decade of how we can treat Barrett's. So the risk of transition of Barrett's to cancer is very low, and it's less than 1% in the United Kingdom. The modern management of Barrett's has improved beyond recognition in the last decade, and therefore I believe the risk of developing an esophageal carcinoma in a patient who's had a TOF is extremely low, and I really want to reassure all those concerns that have been expressed about this. It is a very low risk, but it needs proper management. What we'd want to avoid is uncontrolled reflux and uncontrolled progression of Barrett's. Now, how to investigate reflux symptoms in adult? Well, endoscopy, we've talked about barium studies, acid studies, 24 pH, and impedance studies, and manometry. And I mentioned those briefly. I'm just going to skip through these. This is a standard trace from esophageal 24-hour pH studies. If the pH is less than 4, it's deemed pathological reflux, and you get a graph like this, which is fairly unintelligible, but what you then get is a report like this, and it tells you all about the assessment of reflux. And you can integrate all these different measurements, and you get a composite score called the Demeester score. Demeester was an esophageal surgeon in Los Angeles and devised this, integrating all these measurements, and if you've got a score of more than 14.72, you've got reflux. This patient had 114, terrible reflux. So this is really good objective assessment of the degree of reflux. Now, it doesn't measure non-acid reflux, and we heard a bit about impedance testing, and now the modern way of progressing with this is combined 24-hour pH and impedance testing, looking for acid and non-acid reflux, and it's very sensitive at picking up all forms of reflux. Most patients, as you know, don't go to a doctor and don't need to go with a doctor because they control their reflux with antacids, or the GPs implore them to introduce lifestyle changes, and they do make a big difference. The trouble is, once someone with the reflux has had a sniff of a proton pump inhibitor, they don't want to go back to anything else because they work so well. And omeprazole, lansoprazole, esomeprazole, pantoprazole have revolutionised the treatment of reflux because they work so well. And they do abolish reflux. But these are very, very important lifestyle changes. And I probably turn down at least 50% of patients referred to me for surgery because they haven't given this or these a proper go. And actually, if you do get them to lose weight, change their diet, most people can avoid surgery. And we'll talk about those later if you want to. But sometimes we do anti-reflux surgery. Selection for fundoplication, a minority require this, as I said earlier. Pathological reflux, symptoms poorly controlled by medication. If they're recurrently aspirating, that's a very important indication sometimes for considering surgery. You need to make sure that what their dysmotility is like. They all have some dysmotility. You need to assess it with manometry and barium studies. Esomeprazole is the best proton pump inhibitor. I always insist they've tried that one because it's better than the other ones. And they need appropriate counselling. There is a risk of swallowing difficulties getting bad. And of course, as I'm going to talk a bit about in a minute when I finish, patients don't have reflux in isolation. Patients come to see me saying, well, I've got swallowing difficulties and I've got reflux problems. You've got to work out the balance of risks and doing an operation, which has a very significant side effect of exacerbating known swallowing difficulties. So what do we do? Well, there are three types. There are multiple types of fundoplication, but there's three I'm going to talk about. The traditional one, which is the Nissen, and this is the stomach. We've wrapped the top of the stomach around the lower part of the esophagus. That's called a 360-degree wrap. That is a standard one we do with a normally functioning esophagus without dysmotility. That's what I do in 99% of patients who I see needing surgery, and these are patients who haven't got dysmotility. Now, of course, patients who've had a TOF aren't like that. They often have very significant dysmotility, and most upper GI surgeons will not, and I see this from colleagues around the country, simply will not ever offer anti-reflux surgery to adults who've had a TOF because they're so concerned about the dysmotility. I think it's wrong. I think there are patients, certainly I've operated on, who've had very good results with it, and you can select people out for such surgery if you evaluate them properly. But we tend to do a partial fundoplication for them. And this is a toupee posterior fundoplication, or my preferred one in TOF patients is an anterior door fundoplication, where we simply reconstitute the angle between the fundus of the stomach and the esophagus, the angle of His, and then wrap the top of the stomach in front of the esophagus, suture it to the diaphragm, and that creates an increased high pressure area and is very good at controlling reflux. This is just an operative photo, if you can see that. This is what it looks like. This is a Nissen fundoplication. This is the diaphragm we've repaired there. And if you do, and the varying types, and again, these operations in well-selected patients work well. Now, esophageal dysmotility, it's very common in patients who've had tracheoesophageal fistula. The esophageal motility is often very disordered. They often don't get good peristalsis. Where the join has been, there's almost invariably a loss of peristalsis, and peristalsis across that join is very difficult as well. The contractions are often very low in amplitude. It may be worse if you've got bad reflux, because we know that acid reflux impairs motility itself as well. And often the esophagus, certainly that part below the repair, will empty by gravity rather than proactive contractions of the esophagus. We now use almost exclusively high-resolution manometry. I don't really pretend to understand the physics behind that, but it gives you a nice picture. So this is a time scale. You swallow up here, and this shows the contraction moving forward in time. This is the top of the esophagus, this is the bottom. The brighter the colour, the stronger the amplitude. So it tells you how well the contraction is moving down the esophagus, and it tells you how strong the contraction is. And this is normal peristalsis. Swallowing here, that's what it should look like. This is the old-fashioned studies we used to get, but we don't really get them now. This is someone without peristalsis. It's actually a patient with achalasia. It's not a TOF patient. It's someone who's lost all peristalsis. It's a condition that is a rare condition. We see a lot of it in our unit, but it's a relatively rare condition. But you can see here that there is no peristalsis at all. They swallow, and the contraction, the whole esophagus contracts all at the same time. There's no progression down the esophagus. That's not a TOF patient, but the lower part of the esophagus, below the repair, will be like that. Now, I'm going to say a little bit before I finish about esophageal substitutes, because many patients, or some patients, will have had this done. It's when they're used in the neonatal period, it's usually because there's a very long gap, or occasionally after complications of primary repair. And I see some patients who've had multiple operations in early childhood, culminating with a colonic interposition, and that can be a dramatic success at the time, but they do become redundant as they get older. This is a gastric tube reconstruction. I'll whiz through these. This is the commonest type there, and you can get reverse gastric tubes and non-reverse gastric tubes. This is an operation I do quite a lot of, using a small bit of intestine there to join between the esophagus and the stomach, using a small bowel interposition graft. This is a colonic interposition we do less commonly, but we do it. I tend to use the left colon, but some people use the right, but this can work dramatically well to restore continuity. My last slide, because I know I've just overrunning. What is the real word? Of course, patients don't come to me just with a stricture or just with reflux. They usually have a combination, and they have dysphagia and reflux. You need to work out what's the main problem. You need to investigate, take a history. Is there a mechanical problem due to a stricture? Is there dysmotility? Is there reflux? You need to investigate with gastroscopy and barium swallow as a bare minimum. Other investigations as indicated. The vast majority of patients I see can be managed with a combination of endoscopic dilatations and appropriate optimization of medications. And surgery is actually very, very rare, but you can make a big difference to these patients. So esophageal problems are common. They're complex, and extensive investigations are necessary. You need to define the anatomy and the physiology. You need to consider endoscopic surveillance if they've got Barrett's. They should be looked after by a consultant with a special interest in esophageal disease in patients who've had tracheoesophageal fistula, fairly few and far between. But I think the majority of patients, their symptoms can be improved very, very significantly. Thank you very much.